Right. Hello, 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 everyone. So we are working to get the slides up. However, I want to thank you so much for joining, and we will begin in about 1 to 2 minutes to allow some more folks to join. Right. For everybody joining us now, we are going to start at 6:05, and we are going to put up the slides shortly. So if you need to get some water or grab a snack before we begin, please do so. All right. Good afternoon, everyone. We want to thank you so much for joining us today. We appreciate you taking the time to participate and engage in this thoughtful discussion as we come together under the recognition that we all deserve care without fear. We come together under the notion that however our pregnancy ends, everyone deserves support and the tools and the resources necessary to navigate pregnancy with dignity and self-determination. We recognize that Georgia's maternal health crisis, whereby over 80% of pregnancy-related deaths are preventable, is unacceptable. Where the state-sanctioned violence lingers in our maternal and reproductive healthcare deserts, it lingers in our policies that restrict care through limitations on abortion access and the criminalization of pregnancy outcomes. It lingers in Georgia's failure to expand Medicaid, leaving over an estimated 240,000 Georgians without health insurance. It lingers in our communities, particularly that of Black women who are dying at over 3 times the rate of white women for pregnancy-related causes. It lingers in our providers who are shackled by Georgia criminal and penal law, which has compromised their medical autonomy and ability to deliver timely and adequate care. It lingers in the countless cases where women and birthing people in Georgia are experiencing coercion, loss of autonomy, care delayed or denied, obstetric violence, provider shortages, and even criminalization across this state. The Know Your Rights campaign was created to confront these injustices, bringing together cross-sector leaders that you will meet today to equip Georgians with the tools to navigate a restrictive and often hostile healthcare landscape, because we all deserve joy, not fear. For today's webinar, we aim to reduce fear and misinformation by clarifying who the Georgia Life Act regulates, highlighting its narrow exceptions, and showing how it affects support systems for abortion care and self-managed abortion. We will also review Georgia's common law protections for pregnant people and distinguish legal realities from fears. Importantly, this webinar goes beyond legal analysis alone by convening advocates working at the intersection of law, healthcare access, and community power. By bringing together experts who respond to real-time community calls about urgent legal and safety concerns, as well as requests for abortion logistical care and financial support. We aim to bridge the gap between statutory language and lived reality. Together, we will examine not only what the law is intended to do, but also the harm, the fear, and the confusion it creates in practice. We hope that by grounding legal clarity and community experience, this empowers participants with accurate information, reduces unnecessary fear, and strengthens collective understanding of reproductive justice in Georgia. We extend our deepest gratitude to our esteemed panelists here today, not only for dedicating your time and expertise to enrich this webinar, but also for your passion, your commitment, and your partnership in advancing this movement during such a challenging time. And so for that, on today's agenda, we have welcoming and opening remarks. We are going to be clarifying Georgia's reproductive health laws. We are going to hear from legal professionals on If When How's Repro Legal Helpline and address community concerns. And then we'll also hear from folks at Access Care Southeast, who will be discussing what access looks like in real time. And so I want to welcome you all to Pregnancy and Criminalization in Georgia, a reproductive justice approach. SisterLove. So who is SisterLove? As you can all see with the pictures at the top, that we are SisterLove. SisterLove is the first women's HIV and sexual and reproductive justice organization in the Southeast. SisterLove has been around for 35 plus years, and it was founded by an activist and a trailblazer in this movement, Dazon Dixon Jallow, to eradicate the adverse impact of HIV and sexual and reproductive justice challenges impacting Black women, women of color, and marginalized communities. The Justice Law and Policy Project was established in 2025 in direct response to escalating attacks on our civil rights, our reproductive health, and our bodily autonomy in today's political and social climate. And the Justice Law and Policy Project is SisterLove's legal advocacy arm that works to produce policy reforms. We provide public legal education, we organize within our community, and we conduct grassroots and cross-sector collaboration in order to ensure that our communities have the tools to navigate Georgia's restrictive repro landscape. So what is reproductive justice? Reproductive justice is a term that was coined by a collective of Black women activists, a total of 12 women who formed the Women of African Descent for Reproductive Justice and convened a Black Women's Caucus during a national pro-choice conference in Chicago. These women recognized that the mainstream RJ and repro rights movement focused highly on choice and failed to address the intersecting inequalities that shape their reproductive lives. lives. By framing and reframing reproductive autonomy through a human rights and social justice lens, the founding mothers of the RJ movement deliberately shifted the conversation beyond the narrow pro-choice versus pro-life dichotomy. They introduced a multi-dimensional analysis that considers how all of our intersecting identities, including gender, race, class, sexual orientation, and gender identity, intersect to shape our ability to control our reproductive destiny. How does it work? So the four core tenets of RJ are the right to have children, the right not to have children, and the right to parent in safe and healthy environments. And the last tenet of RJ is the right to bodily autonomy. I am going through these slides a bit quickly because in our previous webinar on advanced directives, which you can find on SisterLove's website, we went more in depth onto RJ as well as the tenets. And so if you would like to just have a more in-depth look on what RJ means and how it functions in practice, please do visit SisterLove's website under the Justice, Law, and Policy Project's Know Your Rights tab. All right, for this next section, I want to provide a legal disclaimer. So I want to ensure that you understand that the information provided in this webinar is for educational and informational purposes only and does not constitute legal advice. Also, outside of that, I want to share somewhat of a community disclaimer. I want folks to understand that sometimes this information we will be relaying is difficult. It's hard to stomach. It's deeply personal for some. And so if you need to stop and get some water, please do. If you need to step away, if you need to go get some air, please do. Because this webinar will be recorded and posted on our website as well. And so you'll have two ways to kind of go back and watch the recording. We want to make sure that you feel safe, that you feel seen, and that you feel heard. And in the end of the webinar, we will have a Q&A where our questions and all questions will be addressed in the order received. At the end of the webinar, you can use the Q&A function at the top to embed your questions. And then we want to encourage a space that functions as an open and considerate discussion and where mutual respect is given throughout the session. Okay, so without further ado, we're going to take a deep dive on pregnancy and criminalization in Georgia. We're going to assess the Life Act. We're going to address facts versus fear, and we're going to work to combat misinformation. I would love to introduce Megan Hill, who is the litigation counsel at If When How Lawyering for Reproductive Justice, who will be working with me on this section of the webinar, and we will move through the slides. Okay, so first I wanted to provide somewhat of a informational on the definitions that you will see, that you will hear throughout this webinar, and that are within Georgia's code with respect to the Life Act and other laws. So the first one is an ectopic pregnancy. An ectopic pregnancy is a pregnancy that occurs when a fertilized egg implants and grows outside of the uterus. It is considered life-threatening. It's a non-viable condition, and it requires urgent medical management or surgical treatment. A miscarriage and a stillbirth, those terms operate somewhat in conjunction and in collaboration and are used interchangeably. However, they do have some distinctions. So with respect to a miscarriage, also known as an early pregnancy loss, it is a non-viable pregnancy and is often referred to as a spontaneous abortion, especially within the Georgia Code, and it occurs before 13 completed weeks on the earlier side or up to 20 weeks of gestation. And then with respect to a stillbirth, it is a fetal death that occurs during pregnancy at 20 weeks or greater gestation. So the way I see it is that miscarriage is on this side of the pregnancy, whereas stillbirth is on the other end of the pregnancy. And then with respect to gestation, it is the period between conception and birth, typically lasting 40 weeks or 280 days from the first day of the last menstrual period. And then with respect to viability, it is the technical, often legal threshold where a fetus may survive outside of the uterus. So within Georgia, Georgia courts as well as lawmakers have defined this threshold as between 22 to 24 weeks. However, the American College of Obstetricians and Gynecologists describes this period to be between 20 and 25 weeks, where a fetus may survive outside of the uterus. Again, that is a threshold. I do want to disclaim that this threshold is a potential for fetus survival and that there is no definitive definition for viability in the clinical sense, as well as there is no succinct definition in the legal sense for viability across our nation. And viability itself is influenced by many complex factors, including gestation and not limited to gestation, that a fetus has if delivered before it can fully develop in the uterus. And this can create some complications when it is written into law. If anything, ASOG strongly discourages its use just because it is more of a potential as opposed to a solidified and more concrete thing. And so when we're using terms like viability within laws to limit fundamental rights for pregnant people, things can get very complicated and they create more of that fear and more of that ambiguity that we are seeing today. Okay, so let's get a little bit into the Georgia Life Act. This is somewhat of a agenda in a way because we're going to go through the exceptions. We're going to go through how it's been applied and not applied, how it could be applied. But overall, the Georgia Life Act was signed in 2019 by Governor Kemp. It is House Bill 481 and known as House Bill 481, and it limits abortion after detectable fetal cardiac activity. So that's around 6 weeks of pregnancy. However, I do want you all to know that pregnancy is still accessible in Georgia up to this point. And I want everyone to understand that that is your right under Georgia law. Unfortunately, at 6 weeks of pregnancy, most people do not know they are pregnant, functioning in practice as a nearly complete abortion ban. Today, we're going to talk about how the Georgia Life Act chills support systems for abortion care. We're going to talk about its connection to our fetal personhood provision in Georgia. We're going to talk about logistical barriers to care within the bounds of the Life Act and misleading and medically inaccurate language and the law and how it creates an environment of criminalization, fear, and uncertainty. I want to also disclaim that for the sake of accuracy and to maintain legal clarity, we will be referencing terminology as it appears in the Life Act, though we recognize these terms as manipulative, misleading, and medically inaccurate, and together we'll critically examine them, clarify their meanings, and work to debunk misconceptions. All right, so the Life Act is riddled with a few terms, and really the Georgia Code and even the Penal Code, which Megan is going to reference later on in this presentation, are riddled with these terms. The first one is human heartbeat, and the next one is unborn child. And so before we go into how the law uses these terms to usurp fundamental rights, we want to make sure that you all understand what they mean in reality and medically. So it is clinically inaccurate to use the word heartbeat to describe the sound that can be heard on an ultrasound in very early pregnancy. This is because no chambers of the heart have been fully developed at 6 weeks gestation, so there is no heartbeat. What pregnant people may hear is the ultrasound machine translating electronic impulses that signify fetal cardiac activity, which later on you'll see how fetal cardiac activity is defined. The Georgia, the Life Act does define human heartbeat as fetal cardiac activity into the sound that we recognize as a heartbeat. And then the next one is the unborn child. So when we center the language on a future state of a pregnancy, it is medically inaccurate. As long as the pregnancy continues, the language should reflect the current state of the pregnancy. Okay, so legal definitions within the Life Act. The first one is going to be abortion itself. It is defined as the act of using, prescribing, or administering any instrument, substance, device, or other means with the purpose to terminate a pregnancy with knowledge that termination will, with reasonable likelihood, cause the death of a fetus. Abortion is not defined as removing a fetus caused by a spontaneous abortion, which, if y'all remember, can be also a stillbirth as well as a miscarriage, or removing an ectopic pregnancy, which again is when a fetus in a single or an embryo grows outside of the uterus itself, which can cause deathly complications. And so, as I mentioned before, a detectable human heartbeat in this bill is defined as embryonic or fetal cardiac activity, or the steady and repetitive rhythmic contraction of the heart within the gestational sac. And then a medical emergency within the Life Act means a condition in which an abortion is necessary to prevent the death of a pregnant woman, to save the life of the mother, or the substantial and irreversible physical impairment of a major bodily function. Medically futile means that in reasonable medical judgment, an unborn child, aka a fetus, has a profound and irremediable condition, so a condition that is incompatible with sustaining life after birth. And then a spontaneous abortion means the naturally occurring death of a fetus, including a miscarriage or a stillbirth. All right, so within Georgia's Life Act, we do have a few exceptions whereby once a pregnant person has passed that 6-week threshold and or that fetal cardiac activity threshold, they can still seek abortion care. These exceptions are that a physician is in reasonable medical judgment determines that a medical emergency exists. So that is in the case of when it is necessary to save the life of the mother, as well as when when an imminent and major bodily function can be damaged, as well as the pregnancy is the result of rape or incest. For this provision to apply, the probable gestational age must be up to 20 weeks, and there must be also a official police report that is filed that alleges the offense of rape or incest. The last one is a physician determines in reasonable medical judgment that the pregnancy is medically futile. That means it would not survive outside of the womb. And then spontaneous abortion, which includes the miscarriage or stillbirth, and an ectopic pregnancy are not considered abortion in the context of House Bill 481, so they do not apply in that case. However, we will see how these narrow exceptions, as well as these narrow legal and medical exceptions in practice, are not easily applied, they are unworkable, and they are causing harm within our communities. Okay, so the ban's exceptions in practice. So in February of 2026, Amplify Georgia Collaborative, which is a collaborative of RJ organizations, including two of the organizations leading this talk today, which is SisterLove and ARC Southeast, and the Center for Reproductive Health Research in the Southeast, known as RISE, released a study examining the experiences for care for pregnancies that might meet the Life Act's limiting legal and medical exceptions. What was found is that the environment creates criminalization, it creates fear, and it creates uncertainty. What was found was that folks and providers specifically didn't know when they could intervene to save the life of the mother under that one exception. And communities also fear that they will be criminalized by having an abortion past that 6-week mark, or even by traveling past that 6-week mark to seek essential health care. And so it's creating this environment of criminalization, of fear, and the law does not align with the nuances of medical practice. It doesn't consider high-risk pregnancies. It doesn't consider other factors that might influence why a pregnant person would want or desire or need a abortion in order to continue a healthy life. Outside of that, it also found that the law necessitates multi-layered processes and documentation that delay critical care. This is in the context of, for example, within the provision and the exception of rape and incest, you do need to file that police report. And many communities, especially today and in today's political and legal climate, are very fearful of the criminal justice system and would not want to enter into a police department or a sheriff's office in order to file a police report. Outside of that, travel is often required, and it poses additional burdens and delays. And so down here, I have just a little bit of a screenshot, you could say, of the study that they released. At the bottom, there's also going to be the citation where you can look up where to find this resource. But if anything, it's also on our resources page that Crystal, who is our director of programs at SisterLove, will put in the chat for folks to also have some legal resources, which are free and confidential. And within there, you can navigate towards the study itself and find all these different community-based stories of denials of care, of deficiency of care, and of delays in care that are causing these harms. But this is Mary's story, the one that I highlighted today. A nurse manager was the one that told it, but Mary had a high-risk pregnancy. She had cardiomyopathy, which is a dangerous heart condition, from her prior pregnancy, and was on a blood thinner. To safely proceed with an abortion, she needed to be weaned off the medication for at least 2 weeks. And she did fall within this exception because there was no fetal cardiac activity that was detected, as well as she hadn't hit that 6-week mark. But in order to be weaned off of this medication, she would have passed that mark. And so her cardiologist and her OBGYN agreed that another pregnancy would be extremely dangerous for her health, but neither provider was able to provide signed documentation attesting to this facilitated treatment under the exception. And so Mary was not able to get her abortion at the clinic. Now, they don't know, and the nurse manager doesn't know whether Mary was able to continue to get care somewhere else. And that is the problem. That is the problem. If you fall within this exception, you should theoretically be able to access this care. But because Georgia's abortion ban does not consider these nuances within a provider and patient relationship, and within the scope of pregnancy itself, it's very difficult to apply the law in practice, and it's leading to these stories, which are plentiful. I think the study itself examined about 25 different stories in Georgia alone within maybe a 1 to 2 year span. Okay. The second story of harm is that of Amber Thurman. Amber Thurman lost her life after doctors at Piedmont Henry Hospital refused to give her a routine dilation and curettage, an abortion procedure, for 20 hours during her miscarriage. Candy was a mom. She was on her way to nursing school, as many folks on this call might know. She had determined that one child was enough for her in her journey and in her life at this time and at that time. And so she traveled outside of the state to seek medication abortion because at that point she was not able to seek it under Georgia law. So when she traveled outside of the state, she did attain that medication abortion. But when she came back, she needed follow-up care. Is follow-up care, essential care, maternal health care. She needed care. And unfortunately, doctors waited 20 hours during her miscarriage to provide that care because they could not determine within their own realms and within the hospital and their own legal counsel, they could not determine at what point to intervene to save her life under Georgia's medical emergency exception. So when doctors finally did intervene, it was too late because they feared Georgia's abortion ban, which imposes on them both a felony conviction and imprisonment up to 10 years and termination of their medical license. Doctors were unclear at which point they could legally intervene because of the language ambiguities in Georgia's abortion ban. Candy Miller was experiencing already a high-risk pregnancy. She suffered from lupus, diabetes, and hypertension. And due to these pre-existing and chronic health conditions, her health and pregnancy were already in jeopardy when she tried to conduct a self-managed abortion procedure at home. She feared Georgia's abortion law, and Candy did not go to the doctor, and she died in her home. Both of these women were prevented from receiving the care that they needed and deserved, and both deaths were preventable. I also want to note that these stories themselves, they were leaked. We were not informed of this information on purpose. These stories were leaked to ProPublica. Afterwards, the Maternal Mortality Review Committee, which assesses pregnancy outcomes and maternal mortality within the state, they were disbanded. The Maternal Mortality Review Committee was disbanded, and two bills were put into the Georgia legislature, you can say, for a vote. However, none of them passed as to reinstate the MMRC. And the MMRC was usurped and reinstated. And now they aren't releasing the names of the members of the people who are sitting within that committee and continuing to analyze why pregnancy outcomes are what they are in this state and why Georgia's maternal health crisis is pervasive. And so it just kind of shows just a continued lack of transparency. And so with that being said, I am excited to invite Megan to continue with this presentation.
Hi, everybody. Okay, so I'm going to start getting into how this applies to criminal law. I hope that it ends up not being scary in the end. So I first want to talk about fetal personhood and feticide laws. So fetal personhood is something that has entered into Georgia law because of the Life Act and because of the passage of Georgia's abortion ban. However, and this has led to a lot of fear, right? We talk a lot about fetal personhood and the concerns that it can cause. And this is not saying that it's not a concern that fetal personhood is not part of the law now. However, as it applies to criminal law, there is a criminal charge for an act that is alleged to have caused the loss of a fetus. This is the one, and we'll talk a little bit more later about a few other ones. But this is important because this specifically, again, addresses a fetus. And you can see all of the different portions of this law. The most important part that you'll see is bolded, that nothing in this code shall be construed to permit the prosecution of any woman with respect to her unborn child. That language is really clear. It is not been interpreted to include the woman because it's right there. So even though we do have fetal personhood entering into Georgia's laws very damagingly in the Life Act, which Gabby has gone over and we'll discuss later too, we do have these presumptions when it comes to the causing the death of a fetus that the woman herself should not be criminalized for that. I also want to talk a little bit about the disposition of fetal remains, which can, in my work, I've seen that be an area that can cause criminalization. The good news about Georgia here is that the law is phrased as every hospital and clinic in which abortions are performed or occur spontaneously, and any laboratory to which the aborted fetus are delivered shall provide for the disposal of the aborted fetus by cremation. It lists other means. The point is every hospital and clinic. So this language is not directed at the woman herself. It is not directed at the woman herself or any conduct that she would participate in to dispose of anything that she had after a miscarriage, an abortion, anything like that. So that is, again, we see this very much being directed at people who are not the pregnant woman. In addition to that, the Life Act does not criminalize abortion for the pregnant person again, and it is not applicable to the penal code. So legislative history for the Life Act shows a very clear intent not to criminalize the pregnant person. In the passage of any of these laws, the idea of criminalizing a pregnant person has never been popular. So that was something, while it is not included explicitly in the law, in some states you will see that explicitly in the law. In Georgia, it's not in there. You can look to the legislative history to see the repeated instances of lawmakers saying they did not intend for this to apply to a pregnant person. We also want to look at general common law immunity. So we just went over feticide. There are a few other code provisions in the penal code that deal with an unborn child. That's assault of an unborn child and battery of an unborn child. I didn't include the main part of this because the important part is that all of these provisions give pregnant women immunity. So it says that in the code, a pregnant woman is immune from this. So what that means is that the Life Act, and again, the Life Act was not intended to apply to the penal code in the first place. So it does not change any of these provisions. No matter what it changed about fetal personhood generally in the law, it did not touch the penal code, and all of these specifics in the penal code that make it so that a woman herself cannot be criminalized, or a person, it says woman in the code, a person cannot be criminalized for ending their own pregnancy. It would still apply broadly. So the takeaway from that is that self-managing an abortion is not a crime in Georgia. Nobody should have to fear criminalization for seeking or having one, and they should be met with compassion and not punishment. So just know that common law, and Gabby will get a little bit more into the case law because we also have case law in Georgia. We have lots of stuff that says that criminalizing the pregnant person is bad. And so that's just a good takeaway. It's not a crime here. And I will turn it back over to Gabby because this is important.
All right. Thank you so much, Megan, for clarifying those statutes and how the penal code does not apply. And for that matter, the Life Act does not apply to the penal code, and they are separate divisions. I want to talk a little bit about this common law immunity that Megan has been bringing up in the case law that supports it. So this is the common law immunity piece. Common law itself is legal precedent, aka case law, but it is specific to Georgia. This is not based on the United States Supreme Court. It's not based on any sort of other courts within the federal system. This is specific to Georgia, and so we hope that it does provide you with some comfort. This is a case that was decided upon by the Georgia Appeals Court in 1998. It was a situation in a case where a woman who was approximately about 8 months pregnant, and she had shot herself in the abdomen with a handgun with the intent to terminate her pregnancy. This resulted in the death of the fetus, and Hillman was indicted for violating Georgia's criminal abortion statute at that time, which is still written within that OCGA 16-12-40, which is similar, and if anything, that's exactly how you can find the Georgia Life Act, right? Both of these statutes are very similar, and they don't create any sort of exception to that common law immunity where pregnant women and women cannot be criminally held liable for the actions that they take upon their own fetus. And so in this case, the issue was whether Georgia's criminal abortion statute, which prohibited certain actions by a person to produce a miscarriage, applied to the woman who causes her own pregnancy loss. The court determined, and they interpreted the statute's legislative intent, which is similar to our legislative intent when House Bill 481 was passed. They concluded that it was not designed to make a pregnant woman criminally liable for a miscarriage that she causes to her own fetus. And so Megan's going to talk just a little bit more about this in depth. However, the court did hold that the criminal abortion statute is intended to punish third parties only. So that's in the case of providers, in the case of helpers. To criminalize, to regulate, really overall is for third parties, aka providers, not itself for pregnant individuals who perform abortions outside of the legal guidelines and not the pregnant woman herself. And so we have that case within our common law. Right. The second one we have is Gaines v. Walcott, which was decided in 1969. I know many people are like, well, Gabby, this was decided in like the 1900s. How does it still apply today? And the reason it applies continuously today is because the statutes themselves, as they are written, and as I described previously, are written in a third party perspective. And it's not necessarily to criminalize the pregnant individual for their own pregnancy outcome. And then the legislative body here in Georgia has not created any sort of exception to the Georgia Life Act so as to eliminate that common law immunity and eliminate these cases from taking precedent and being able to kind of protect pregnant folks in that regard. And so the facts of this case is that it was a woman who had consented to an abortion, and she had filed an action because she wanted to recover damages against a chiropractor who, with the woman's consent, performed an abortion procedure on her. And so the case was dismissed by the Georgia Court of Appeals as well. And the reasoning was that a woman on whom an abortion is performed cannot be an accomplice in her own abortion. This was kind of touching on different tenets with respect to her consenting to the abortion outside of the legal guidelines. However, there is an additional provision, an additional explanation and reasoning that the court gave that said that the female upon whom a criminal abortion has been performed is not an accomplice with the perpetrator of the offense, as she cannot be indicted for that offense. So I will throw it back to Megan so that she can talk about how House Bill 481 child support systems for abortion care with regard to providers and helpers, given that the Life Act itself is written in the third party.
So as we've talked a little bit about the Life Act, and it's very good news that it is not wanting to criminalize the pregnant person. However, it doesn't mean that the Life Act is not here to very much chill support systems for abortion care. So the Life Act reads, a person commits the offense of abortion when he or she administers any medicines, drugs, or other substance to any woman or upon any woman with the intent to produce a miscarriage or abortion. A person convicted of the offense of criminal abortion shall be punished by imprisonment for not less than 1 nor more than 10 years. So just simply reading this is going to, we will call it, it provides an air of criminality to anything that you are doing with relation to helping somebody seek abortion care. And that is the real damage of HB 481, in addition to the fact, which we'll discuss later, that we have seen people investigated and things, which is problematic. The other really, really problematic part of this is that it does add an air of criminality to any receiving of abortion care, even the stuff that might seem perfectly legal or might be perfectly legal here. There's just a general fear now for people helping somebody seek an abortion, or for a provider, a community provider, a physician, anybody who wants to assist a person with abortion care. So that's really the real damage of this, is the just sort of chilling effect and the fear that it's creating amongst everybody that's trying to help people seek care. So the law was written to regulate providers and helpers rather than women. That means that providers and helpers do still, as you read with the law, incur some liability with relation to the criminal abortion law. That's something that people who are assisting anybody in receiving abortion care just have to simply be careful of. Again, we know what Georgia's law is. That doesn't, there are still some ways that you can seek abortion care in Georgia. We will also have some lovely people speaking after me about what happens if you need something outside of Georgia and what happens if you are not falling within these exceptions and you don't want something bad to happen to you. But that's really what the law regulates, and that's where it really creates these really, really problematic effects on support systems for people. And again, we have seen some instances of criminalization despite common law immunity. So it's just something to be on the lookout for. However, in these cases, we've had district attorneys not charging due to the clearness of the law. In 2015, in Dougherty County, Georgia, a woman was charged with malice murder because she took abortion pills. It resulted in the delivery of a very, very premature infant that lived very briefly. In that case, the district attorney dropped the charges. The DA's office issued a public statement that concluded Georgia law does not permit prosecution of a pregnant woman for any alleged acts relating to the end of her pregnancy. The DA also concluded that applicable criminal laws and statutes provide explicit immunity from prosecution for a pregnant woman for any unlawful termination of pregnancy. And we discussed Hillman. Hillman is the controlling case for this. So that was a very, very clear statement that malice murder, it does not apply to a pregnant person. In 2025, this was more recent, and some of y'all may have seen this on the news. There was a woman in Tifton, Georgia, who was arrested for allegedly disposing of the remains of a 19-week fetus in the dumpster outside of her apartment. This was a miscarriage. There was no contention that this was due to abortion care. She was arrested. She was charged with concealing the death of another and abandonment of a dead body. The DA dropped the charges pretty quickly afterwards, stated the law is clear for both the concealing the death of another and abandonment of a dead body. The deceased must be a live person, and this fetus never survived outside of the womb. So those are two cases in which, again, investigations were initiated, and in both cases, the district attorney read the law and determined that the law did not apply to a pregnant person, and they could not move forward with these. Still something to note, just because people, we'll kind of get this thing, I see this a lot in my work, where people will arrest somebody and then kind of be like, no harm, no foul, I've let you out. And, people still experience very real state violence when interacting with these charges. I'll shoot it back over to Gabby.
So I do want to just emphasize Megan's point that although the Life Act does not necessarily criminalize pregnant individuals, the act of arrest itself, having to be in jail, not being able to work, not to be able to take care of your children at that time is harmful. And I also want to note that these acts of, you could say, pre-criminalization have been against and towards and have disproportionately affected Black women. And the cases that I just described of Candy Miller, Amber Thurman, and even in the case of Adriana Smith, although we understand that Adriana Smith, with her case, Georgia's abortion ban, didn't necessarily create a mechanism for providers to have kept Adriana Smith on life support until the point that her fetus and her pregnancy reached viability, these laws themselves in practice are unworkable. They're creating these delays in care, these denials of care, this fear and this ambiguity. And so we certainly wanted to go through the law with you all so that you can understand that abortion is still accessible in this state before that 6 week and really how to discuss and how to know your rights around those medical exceptions, so that we don't continue to have cases like that of Candy Miller, who had died in her home because she did not feel that she could seek that medical emergency. She couldn't seek care under that medical emergency provision within Georgia's Life Act. And so with that being said, I wanted to move into more state-specific policy recommendations and model legislation. So House Bill 589 and SB 246 is the Reproductive Freedom Act. That is an act that is also a campaign housed within Amplify Georgia Collaborative, which I described earlier is a collaborative of community-based organizations, including SisterLove and including ARC Southeast, who are vehemently behind this bill. This bill, although it did not cross over, really it didn't even get a hearing during Georgia's 2025 and 2026 legislative session, abortion, which is very unfortunate. But what it would do if passed, and mind you, it will get reintroduced in Georgia's 2027-2028 legislative session happening next year. But what it would do if passed is it would protect abortion rights. It would roll back restrictions on abortion. So that would be those restrictions laid forward with respect to a police report, with respect to having to have an ultrasound to detect that fetal cardiac activity. It prevents pregnant persons from criminalization stemming from pregnancy loss. So although a person has not been convicted fully under the Life Act for decisions made with respect to their pregnancy loss, this would ensure that people do not experience that pre-criminalization with respect to arrest, which is, what we're trying to combat and fight against. And it would also expand access to safe abortion care, because what we understand is that when Dobbs was passed, right, which was the Supreme Court case that usurped Roe, which created fundamental rights for abortion access nationally. What we understand is that when that happened, states like Georgia that had trigger bans, mind you, Georgia's trigger ban was introduced and passed in 2019, but it wasn't able to be applied until 2022, aka trigger, until the Dobbs decision was passed, right? And so with that being said, what we understand is that Dobbs itself, the ripple effect that it had is that many providers are leaving the states with bans. And it is creating even wider gaps within Georgia's maternal health crisis and within its deserts, whereby over 50% of counties have no OBGYN, where folks have to travel more than a 30-mile radius just to access basic care. And what we also understand is that abortion clinics themselves offer way more than just abortions. They offer STIs, they offer STI testing, they offer HIV testing, they offer community-based and centered sexual health education, such as SisterLove, right? We are a sexual health and reproductive justice organization. We also offer STI and HIV testing at our mother house here in Ralph David Abernathy Road off of in Metro Atlanta, right? Just kind of a plug for SisterLove. But, the abortion clinics, they don't just offer abortions, right? And so how this functioned and how the Georgia Life Act continues to function is that not only is it harming communities in the sense that it's delaying care, denying care, and creating further harm, and in some instances even death, right? In the case of Amber Thurman and Candy Miller, but it is also widening these maternal health care deserts that are exacerbating our maternal health care crisis. And so what the Reproductive Freedom Act would do is kind of stand within that gap to prevent these sort of cases. Outside of that, we would recommend to repeal the Georgia Life Act, and specifically the fetal personhood language it carries, to affirm that legal personhood begins at birth. Not at once an embryo, not at a single cell, not at the moment of conception, right? We recently had a bill that was floating around the Georgia legislature. Fortunately, it did not cross over, right? Bills need to cross over from one chamber to the other, and then they need to be voted on. And then, of course, they go to the governor after that to be signed. But point is, it did not cross over. Therefore, it is dead. And so with that being said, there was a bill that was introduced in the Georgia legislature relating to making sure that fetuses and really embryos and single cells were considered and had that fetal personhood, thereby were considered natural persons under the law. And so, fortunately that did not pass. However, what we do want to affirm is that legal personhood and those rights and being considered a human being under the law begins at birth, and no civil, criminal, or regulatory consequences may be imposed based on a person's pregnancy outcomes or status. Outside of that, we also want to protect patient privacy. So we want to establish statewide privacy protections for all pregnancy-related medical data, including autopsy reports, fetal remains, toxicology tests, and fetal tissue. One thing that I recently saw that Crystal, who is on this call, and she is so graciously changing these slides for us, sent me is that DNA has been used in order to pre-criminalize a person later on once the DNA was found to be linked to somebody who has had an abortion. These cases, right, that we have seen that really are just public knowledge that you could look up are cases where these women are 55 years old, right? 55. I think there's another one that was even you know, a little older than that, right? And they are being now investigated for a abortion or a pregnancy decision, right? That they made 20 something years ago simply by signing up and providing their DNA over to ancestry.com, for example. And so with that being said, what we need is statewide privacy protections to ensure that this medical data is not used against pregnant individuals and that their decisions are kept private. Outside of that, we want to establish statewide restrictions on law enforcement access to medical records, coroner reports, or hospital records in cases of pregnancy loss. This really could be done through a bill and through legislative advocacy. Okay, for the state-specific policy recommendations continued, we want to affirm by legislative resolution or legislative bill that in Georgia, providers are not legally required to report to law enforcement if they suspect a patient has had an abortion, and particularly a self-managed abortion, which is the process of ending a pregnancy outside of the traditional formal healthcare system. So this typically means the process of taking misoprostol as well as mifepristone, right? And so, and kind of not wanting to be within the formal maternal healthcare setting or within the formal hospital setting and wanting more of a private abortion, right? And so with that being said, a lot of these cases as well that Megan was bringing up were cases where providers were the ones kind of tapping on the shoulders of law enforcement to let them know that there was a suspected, right, a suspected case of a self-managed abortion. And one thing that we want to be clear that providers know is that they're not legally required and they're not mandated to report to law enforcement any sort of suspicion that a patient has had an abortion. We also want to restore advance directive rights for pregnant people in Georgia by repealing the state's pregnancy exclusion law. This law, the pregnancy exclusion law, works to disregard pregnant individuals' advance medical directives if their pregnancy is considered viable, or in the case of a pre-viable pregnancy, if they do not have pregnancy-specific instruction in their advance directive. So one thing that we are all clear on within the legal realm is that in the case of Adriana Smith, who was the woman who was kept on life support until her pregnancy reached viability. One thing that we know to be clear is that if she had an advance directive, which is really a way for you to kind of write down and make sure that your medical decisions in advance are adhered to, just in case you become incapacitated or ill and you're not able to kind of explain in real time what you want and explain what your decisions are. This document you can write ahead of time and known as an advance directive, and from there then doctors know, even if you do become incapacitated or you are in a condition where you can't speak for yourself, they know what you would want, right? And what we know is that in this case, in Adriana Smith's case, if she did have an advance directive, then it provided no protection to her or her family in terms of a say in her end of life care. And so that's where you hear a lot of information within just like the media realm describing how her family, specifically Miss April is her name, had no say into her daughter's end of life care. And so the last policy recommendation that we have is to support Georgia's Maternal Health Momnibus Act. So several states have joined in on the Congressional Momnibus Act, which was first introduced by Congresswoman Adams and Congresswoman Underwood in order to provide just more comprehensive and culturally competent policy that addresses the country's maternal health disparities that are particularly impacting Black women. And so once this congressional Black Maternal Health Omnibus Act was introduced, a lot of states, and in the policy realm, what states do is they kind of piggyback. And so California, North Carolina, Michigan is not on here, but Michigan as well, and Illinois started to introduce their own state-specific omnibus that was full of comprehensive policies to close that gap within their maternal health crises, right? And so what the Georgia Maternal Health Omnibus Act does and how it specifically applies to Georgia is that it would address those social determinants of health, such as transportation, which make it really difficult for women and pregnant individuals considering Georgia's maternal care deserts to travel to a clinic to go to their prenatal visits and to make sure that their pregnancies are healthy. So it would ensure that those social determinants of health, such as transportation, are addressed, as well as it would invest in data collection with an intersectional framework. It would diversify the perinatal workforce, so that includes doulas, midwives. It would also combat racism and implicit bias in healthcare settings and systems, including the implementation of compliance programs throughout the hospitals in Georgia, which, if established, would allow for pregnant individuals to be able to file claims of discrimination, and just an easier mechanism to file those claims of discrimination if they are going into a medical system or a hospital, right, a maternal health care setting that is actively showing, racist oppression, right? And so that's where you're seeing other cases across the nation where Black women aren't being listened to. So we can continue from that. And I think now we are done with this section. And so I am very excited to welcome Elizabeth Ling, who is the Associate Director of Legal Services at If When How. Thank you so much for being here.
Thank you, Gabby. And thank you, Gabby and Megan, for that extremely thorough explanation of Georgia's laws, as well as people's real lived experiences, because I think that's the exact backdrop or context for why we offer the services that we do on the Repro Legal Helpline. So like you all were just saying, right, people all over the country are scared and confused. Laws are rarely, if ever, written in clear and accessible terms, right? And they're never black and white, right? Because laws are applied differently to certain people and to certain situations, because state actors have tremendous power in that decision making, right? And so something that every helpline caller will hear us say is that what the law says and what happens in reality can and oftentimes is different. Next slide, please. So our goal in the helpline is first and foremost to provide anyone anywhere in the country, no matter their age or immigration status, with free and confidential legal services for their reproductive life. That can include talking to someone about their legal risk of a self-managed abortion, but it can also include talking to someone about their rights during birth, or parents' rights who maybe are experiencing a family policing case. We also talk and support people who are being denied emergency abortion care, even when their life is actually at risk, right? And the provider is simply too scared or having their hands tied by other lawyers. Sadly, over the last few years, it has been abundantly clear that more and more people need a lawyer to navigate their reproductive life. Next slide. And so since 2018, we have responded to over 11,500 calls. The vast majority of these calls followed Dobbs, when our call volume jumped from about 300 in a single year to that same amount in just about every single month now. Next slide. And unsurprisingly, most of these calls will come from states with some of the most severe abortion restrictions, right? And you'll see Georgia ranks consistently in the top 5 states just about every month. But actually, we get calls from every single state, right? And we've gotten calls from all 50 states, as well as several US territories, because again, we know that the right to an abortion was never enough, and reproductive justice, as Gabby went through, is never just about abortion. Next slide. So what do people call to talk to us about? Again, unsurprisingly, the most common reason we get contacted is because people are worried about getting into legal trouble for ending their own ending their own pregnancy with abortion pills. The specific concern might be different each time, and actually oftentimes reflects what is happening in the world, right? And so our job as lawyers on the helpline is to help callers parse through that overwhelming fear and confusion to truly understand like their specific legal risk based on their specific circumstances. And so yes, everything that Megan went through is very real, right? And pregnancy criminalization is not at all hyperbole. We also know that many people can and do end their pregnancies in the safety and privacy of their own home without experiencing legal consequences. Next slide. So what are folks in Georgia actually calling us about? Exactly what I was saying earlier, right? People are scared about ordering abortion pills. They are confused about Georgia's laws. Everything that Gabby walked through in terms of, is it 6 weeks pregnant? Is it less than 6 weeks, right? These are the nuances and the details that people don't often know because, again, laws are not intended to be clear, right? These laws are intended to be confusing. They're intended to be complicated. And so our job, again, is to give people all of the information that they need to make a fully informed decision about their pregnancy, and to also make sure that they are prepared if they ever actually do need the help of someone like Megan. Because we know that quick access to high quality legal representation is perhaps the most important when people are faced with actual state violence. But the questions range, right? So it is questions about state violence. It is questions about how do I talk to my doctor if they already knew I was pregnant? Gabby alluded to this earlier, right? People are reported to the police by their healthcare providers. And so they know and they are scared about all of the things that Gabby and Megan talked about. And so again, our job is to tell them or talk to them and provide them an individualized assessment about what is your legal risk, right? And what are ways that perhaps you can mitigate your legal risk. Next slide. So how can people get in touch with us? People can call or submit an online form. And our policy on the helpline is that every single person who calls us, even if we may not be the exact right resource to them, gets a call back. It really helps us when folks share their full name, their age, their state, and the reason they are calling so that we can triage how quickly it is that we should get back to them. And everything that people share with us on these conversations, they're fully confidential, and we never record our phone calls. And so we do operate as a warm line, which means that we are available all the time, weekends, overnight, but most people will get a call back within at most 2 business days. Honestly, in practice, it's less, unless you're facing some type of legal emergency, which we define as being contacted by the police, the family policing system, or more commonly known as child protective services, or even immigration because of a pregnancy decision that you made or a pregnancy outcome. And so our hope is that people will never need us and that we will not need to connect people to folks like Megan. But if they do and they need us, then we have created a really, I think, robust rapid response system so that folks are connected to that defense attorney. They're connected to other resources like bail funding as close in time as possible. And that's important because we know the fight against state violence truly is not possible without all of us, right? And so we rely on local advocates like Gabby, like the folks at ARC Southeast who are going to speak next, to make sure people have what they need and can feel safe in community.
Thank you so much, Elizabeth, for that wonderful description of all the resources that are provided by the Repro Legal Helpline at If, When, How. Again, Crystal should have put in the chat at least the resources that we have provided, and you can navigate to those resources to find the Repro Legal Helpline. And it is my honor now to introduce Zoe Bombara, who is the Community and Volunteer Engagement Coordinator at ARC Southeast, known as Access Reproductive Care Southeast, and Alexis Casas, who is the Healthline Coordinator of Access Reproductive Care Southeast as well, who is fielding real-time community calls of folks who are wanting to seek abortion care and need logistical and or financial support. So thank you so much for being here today.
Of course. Hi, everyone. I will start us off. Like Gabby said, my name is Zoe Bambara. I'm the Community and Volunteer Engagement Coordinator at ARC Southeast. We are an abortion fund. We're a Black-founded, Black-led abortion fund, the largest and most restricted one in the South, and the only abortion fund in Georgia, which people don't know. And we can go to the next slide. So our mission is to provide funding and logistical support to ensure Southerners receive safe and compassionate reproductive care, which includes abortion services. That's where the bulk of our budget goes towards is abortion services. Through education and leadership development, we build power in communities of color to abolish stigma and restore dignity and justice. We can go to the next slide. So like I said, we're the most restricted and the biggest abortion fund in the South. We cover 6 different states: Georgia, Alabama, Mississippi, South Carolina, hold on, Florida, and Tennessee. Did I say that already? Yeah, the Southeast. We're only missing a couple. We're missing, like, hopefully one day we'll get to like North Carolina and Kentucky and, all the places below the Mason-Dixie. But right now we only cover 6 different states. 84% of our callers identify as BIPOC, which is really great considering that I would say more than 90% of our staff identifies as Black. So we're actually like being able to serve people who look just like us. 68% of our callers are already parents. And I think we've talked about this a little bit previously, but also like moving forward, it's really important that we look at RJ as something that's extremely expansive. Like we said, most of the people who are trying to receive care are already parents, and are needing, support with the children they already have. And so it's really important that we look at RJ as not just abortion, but beyond abortion. And 69% of our callers identify as religious. Yeah, we are in the Bible Belt. So there, people are going to be a little religious. And we can go to the next slide. So, like I said, RJ is expansive. So it's not just abortion that we do. We also have really awesome mutual aid programs. So like some of the things that we have: financial assistance. So say someone is further in the gestational period and needs to go out of state, we cover those costs if they need a flight, or if they need a bus, a train. I don't know, people still take Amtrak, but a train. If they need Uber Eats vouchers, if they need childcare, that's something that we're trying to pilot soon. Whatever they need, we want to make sure that they're able to receive accessible and compassionate care, and building and bridging those gaps. We also have our Safe and Sustain Fund, and that's more of like material needs. That's more like meeting the material needs of people. So that's like direct income. We do $500 over 10 months to 10 people. And we also have our Repro Access Fund, and that's for people like if, for their children, if they need shoes, they need a doula. We had a caller who continued with another pregnancy and decided that they wanted a midwife, so we were able to pay for their midwife services. It's like we said, RJ is very expansive. We have abortion aftercare kits. They include Plan B, pregnancy tests, ovulation tests, ginger candy, menstrual pads, things that you'll need after your procedure. And we also give away Plan B throughout the 6 states that we advocate in. And we also do a peer support group for our callers after, if they need just to be in community and to love on community. I always say you can't heal in isolation. So it's really awesome to have this space. And then we also have many community events and political education, volunteer program, et cetera, et cetera, et cetera. And we can go to the next slide. So in-state abortion care is limited to a 6-week ban. Fewer clinics provide abortion care in the state. Of course, as when Roe v. Wade was overturned, a lot of places had to close because they no longer could, stay open, could afford to stay open. And many Georgians must travel long distances for services, or they have to, catch a bus, catch a Greyhound, catch a flight, whatever it takes. And then people are increasingly relying on support networks like abortion funds to handle those financial hardships. And we can go to the next slide. So this is just from an NPR interview. I think it's really important we get stuck in numbers a lot, but these are real people with real hardships and real obstacles that they have to overcome. And so I wanted to include this interview question of a doctor who is an OBGYN and a family planning specialist in Atlanta. They said they had to take care of a 15-year-old who came in and didn't realize she was pregnant until after 6 weeks. Because if you think about that, 6 weeks from the last menstrual period is 2 weeks from a missed period. That is hardly any time for people to realize they're pregnant. And as someone who Like me, I do not have regular periods. I know TMI, sorry, but I don't. So it's really hard to stay a track if you don't have a regular menstrual cycle. But this is hardly any time for people to realize they're pregnant, to be able to come in for care, particularly folks like adolescents or people with irregular periods, aka me. It's just really hard to be able to get in that time frame. It just makes things a lot harder for everybody involved. And we can go to the next slide. So some of the barriers to care that Georgians are facing, we're going to talk about Georgia specific because we are in a call with, this is Georgia specific webinar. The cost of care, the cheapest abortion in Atlanta is $475, average being $600. I don't know about y'all, but I do not have that laying around. So that's why abortion funds are very important. Travel and transportation challenges. A lot of people may not have access to a car or be able to drive themselves. Timing restrictions, limited appointment availability. And I know Alexis will probably go in a little bit deeper when it comes to that particular barrier, but I do want to say that, like, in some states, if you're receiving if you're going to go there for a procedure because you can't get it in Georgia, you have to stay 24 hours after your procedure. And sometimes you have to come in like the day before. There's a lot of like rules and regulations, and people have to work. And they can't afford to miss a couple days of work. And of course, these are all just more barriers to care. Finding childcare, fear and misinformation. We see that a lot. The opposition works very hard to put misinformation and disinformation in the streets. It makes our job a lot harder because people love a deep fried Facebook meme and love to spread those pictures. And it's like, bro, where'd you get this information from? And then we also have fake clinics. And fake clinics, they will literally, I've been to clinics where like actual abortion clinics are right here, and then fake clinics will be right here, and then the fake clinic sign will be bigger than the abortion clinic sign because they get more funding from their county or their city or their state to do that, to be annoying. So it gets really difficult for people to differentiate where they're actually going and what's an actual real clinic and what's someone pretending to be a clinic. And we can go to the next slide. So fight back. I know Gabby kind of talked about Amplify Georgia and like the collaborative of all the RJ orgs. Well, some RJ orgs in Georgia to push for the Reproductive Freedom Act. But I think it's really important that we know our local, state, and federal elected officials who champion for reproductive health access. Because like we said, we live in a state where we live in a reproductive healthcare desert. Georgia has one of the highest Black maternal mortality rates. And so with that being said, and we've had over 10 hospital closures in the past 15 years, it's really important that we understand that abortion access is vital for us to not only survive, but to live in our bodies. And so I hope that we all can go and find our elected official and keep and be annoying. I love being annoying. Be annoying, call their phones, email them, show up to legislative session, do what you have to do in order for all of us to receive the care that we can. Because like we said, Senator John Ossoff convened the hearing for the committee. That committee had identified hundreds of reported human rights abuses against pregnant and postpartum women who were serving in prisons and jails. So it's so many factors when it comes to RJ, and we just want to make sure that we're all like fighting for each other. And we can go to the next slide. Again, talking about the Reproductive Freedom Act and with Amplify Georgia, I hope that you all can look it up afterwards and find a way to get involved with that organization to see if you can volunteer to push for the Reproductive Freedom Act. Because like we said, we Black people, Indigenous people, other people of color, immigrants, women, queer and trans folks, young people, people who live in rural areas, there's so many barriers to care, and we have to join together to fight those barriers. And we can go to the next slide. Okay, so 1 in 4 women will have an abortion by the age of 45. 60% of people having an abortion are already parents to 1 or more children, and 77% of Georgia voters support reproductive freedom. So I talked about the amount of Georgia, like the hospitals that have closed. 90%, 95% of Georgia's counties, over 150 out of 159, do not have an abortion clinic. Also, a lot of these counties don't have an OBGYN. There are only 15 clinics that actually provide abortions in Georgia, and they are located in the other 5% of Georgia's counties. So like I said, there's a lot of barriers to care, especially I always say in Georgia, I don't go past Macon, I don't go past Athens, because one, it's just too far. And also two, I know better. But people do live in those other counties, and we just want to make sure they're able to have, access to care. And I will pass it to Alexis.
Thank you for that overview, Zoe. While those numbers show us the statewide picture, I want to kind of bring us closer to home with some statistics from our Healthline. So just in February, we supported 473 callers, and this is within our region. So going back, this isn't just Georgia, this is Georgia, Tennessee, Alabama, Mississippi, etc. But I do want to pause there. We assisted 473 individual people. So that was 473 different situations and people who needed help. In that same month, we distributed over $232,000 in funding appointment cost and more than 16,000 in practical support. That includes things like transportation, hotel stays, rideshare, food, and more, because for many people, the barrier isn't just the procedure itself, it's everything around it. The average cost of care was about $1,738. So imagine needing that amount of money quickly, unexpectedly, while also managing things like work, school, family, and everything else going on in life. And then 66% of our callers that didn't even include staying locally, they had to travel. So travel means time off of work, as Zoe stated. It means coordinating schedules. It means added expenses that can change at any moment. And so most of our callers were from Georgia and Tennessee, and a lot of them also went outside of Georgia, and we're seen in like states like Illinois. I also want to name that 94% of our callers identified as BIPOC. So our statistics are still ringing. The people that we are serving are still people of color. And that tells us something really important, that these barriers are not neutral. They are falling hardest on communities that are already navigating inequities in healthcare, income, and access. So when we talk about these numbers, what we're really talking about is who is being impacted and how deeply. We can go to the next slide. So let's talk about what we're actually hearing when people call. People reach out for very practical reasons like funding, seeking accurate information, help navigating logistics around their appointment, and finding additional resources when gaps remain. But underneath that, there's something deeper happening. We're hearing a lot of fear about legal consequences, people asking, is this allowed? Am I going to get in trouble for this? We're hearing confusion because the laws are complicated and constantly shifting and not always clearly communicated, even within clinics where turnover rates are high and the retraining of new staff members and stuff, things are not being communicated as accessibly, as easily. We're hearing concerns about privacy, people wondering if calling or seeking care could somehow expose them. And then there's that stigma that some callers lower their voices, some hesitate using the word abortion itself. Some people are apologizing constantly for even needing help because they feel silly and embarrassed. And we also hear impossible choices, people choosing between paying their rent or feeding their family, or maybe keeping the lights on in order to get this type of care. They're making some type of sacrifice. And for some, there's no one at all to talk to. There's no partner, no family support, no friends. They feel safe telling. Others are navigating internal conflicts, especially when their personal or religious beliefs don't align easily with their situation. And then again, when we ask whether these policies create fear or stigma, we don't have to guess. People are telling us directly every single day. We can go to the next slide. And so what kind of this care looks like in real time, we see a lot of delays, often because people are trying to figure things out on their own first, or are afraid to reach out, or simply are unaware that there are resources available like ARC Southeast. We see increased travel, sometimes across multiple states like North Carolina, Virginia. Specifically, if you're in Georgia with that 6-week ban, oftentimes you are traveling to North Carolina or Virginia. If you're past 12 weeks, it's usually Virginia and Illinois. And then 24 weeks are going out even further to like Pennsylvania, New York, New Mexico, etc. And so for some of these people, like this is the first time they're traveling completely, the first time they're flying, leaving their home state, their hometown, whatever it may be. So that's already nerve-wracking. And then they're getting a procedure somewhere that is so unfamiliar that they have little information and they're just consuming all of that. Something else. Oh, and so of course, costs also are not always predictable. When you're thinking about that $1,700+ for an average abortion, including travel, hotel stay, the appointment costs, etc., that's a lot of money. I actually worked with a caller recently who needed full practical support, and everything was booked right on time. And the day of, trying to get to her flight in Georgia, she's about 3 hours out in a suburb city. There was no Uber that was going to come to get her, so she had to drive her vehicle with very bad brakes to the Atlanta airport. So that means I had to, in real time, find what the parking cost is going to be. Then we get to her appointment, and the clinic is like, you're actually not going to be out of here by 8 o'clock for your flight. And she was there from 8 a.m. to 8 p.m. And so in real time, I had to call her and see like what's going on, what does she need? And a lot of that was her thinking she's going through this appointment in pain, already taking the pills, things are getting started, and thinking about she has 2 children at home. Like, how is she going to, she didn't have any money for the babysitter. How is she going to get more money to pay for the babysitter, to ask the babysitter to stay? How is she going to have more money for food? How is she going to change her flight? How is she going to extend the hotel? So in real time, we're building these gaps because now whatever we paid for the practical support is being extended. It's costing more. And those are funds that, she didn't have, and time that she didn't have. Excuse me. I believe we can go to the next slide. Yes, I summed that up a little bit faster. But yeah, so kind of what our Healthline is. Hearing stories like this, we see it all the time. There's so many similarities and so many differences because everyone has their unique obstacles to overcome and their unique limitations to access. But to be clear, we are warm line, which means you can call and you'll leave a message and then we will return your call. All conversations are confidential. They are not shared. They are not reported whatsoever. And I want to say this again, calling for support does not mean reporting yourself. You are not getting yourself in trouble by asking for help. There are no income requirements. We are multilingual. Your immigration status does not matter to us. And this is a space designed to support people without judgment, without surveillance and without punishment. And so our Healthline number is there. Our hours are Monday through Thursday. I think we're hotlining still Fridays, but from 11 to 2 p.m. you can leave a voicemail for support. And the next slide is just additional resources. So if you need further support, whether it's before, during, or after your abortion, this is kind of where you can find us. Thank you.
Thank you so much. Thank you so much. So with that, we can begin the Q&A session. I am so sorry to all the attendees. We probably have time for maybe one question. We had so much information to share today, but what I will say and what I do want to plug is that we'll be having a second webinar on pregnancy criminalization, where many of the panelists that are here today will also be taking part in that panel discussion on April 22nd at 6 p.m. And it'll be related to pregnancy criminalization, but the lens will be on substance use as well as family policing. And so if there's any questions that we're not able to answer today, you may also have those questions answered in that webinar. And so with that being said, you can navigate to the Q&A portion. There should be a chat at the top if anyone has any questions. And then while we wait, I'm going to give about 1 minute for a question to come in. And during that time, I'm going to put in the chat our free and confidential resources. as well as I wanted to plug in that SisterLove, as well as the RJ ecosystem really in Georgia, will be at the Georgia Capitol this Friday from 9 a.m. to 2 p.m. We will be speaking, as well as we will be really holding the state accountable for the deaths of Amber Thurman, Candy Miller, and Adriana Smith. The mom of Amber Thurman, as well as the mom of Adriana Smith, will be speaking at a press conference. And then the sister of Candy Miller will also be present in order to hold the state accountable for the deaths of their family members and their daughters. And so with that being said, I'm going to put in the chat as well just information on how you can attend. It'll be in the form of somewhat of a funeral procession. At least for the press conference as well as the event on the 27th. And then I know I had alluded to the recent report that is describing the delays in care, the denials of care, and really just overall the deficiency of care in Georgia that we are experiencing as a result of these ambiguities within the Georgia Life Act and within Georgia's restrictive repro policies. And so I wanted to also plug that in as a resource in the chat. So if anybody wants to access that report, please download it, share it, discuss it at the dinner table, because that's when change really happens. And so let me just go to the Q&A and make sure that there's no questions. All right, there are none. So with that being said, I want to go ahead and close this out. I want to thank all of our panelists and every participant here today for joining us in this second episode of the Know Your Rights, You Deserve Care Without Fear campaign series. You deserve care that honors your dignity, your choices, and your humanity. Together, we're building the tools and the power to make that reality across Georgia. Stay tuned for episode 3, right, on April 22nd at 6 p.m. And until then, take care and keep fighting for care without fear. Thank you, everybody.